What are the charges in vaginal wall prolapse surgery? It's not a single entity. Once prolapse surgery means automatically we have to think the multiple surgeries. Like anterior, it includes anterior vaginal, apical, posterior vaginal wall surgeries. During when we are at PGs or when we are doing vaginal surgeries, the VH, suppose one case is posted for VH. Once hysterectomy is over, we thought like surgery is over. So it's not after coming now. Once I've been consultant after reading this so much and understanding this, I came to know that hysterectomy is not the. It's only corresponds to 40 to 50%. Remaining repairs also plays a major part in the prolapse surgery. And actually, once hysterectomy is over, hemostasis also takes nearly 45 minutes or 1 to an hour, 20 minutes like that. Meanwhile, our patients will and hemostasis also makes so much of irritation sometimes when bleeding is more. So with that, what we will do, with less patients will be irritated with irritation, the remaining procedures, whatever they like anterior colporrhaphy or posterior colporrhaphy, some people may skip that or some people may do improper correction. It won't be like that. Even though we are irritated or we don't have time, we lost the patients because of time consuming procedures. We have to do all procedures till the end with proper corrections, with proper how we started the surgery. We have to end the surgery also with the same intention. And this is the level 1, level 2, level 3. We know all this in which uterus and level 1 suspense uterus and vaginal defect can cause uterine prolapse, wall prolapse, rectocele. Level 2 defect cause cystocele, electrocele, rectocele. Level 3 defect can cause renal hypermobility, electrocele and SUI. This is the diagram presentation. Main objects of the vaginal wall surgery includes preserve the normal vaginal wall axis, minimize complication rates, reduce blood loss, less postoperative discomfort and low cost. Repair all coexisting pelvic floor defects. Mainly we have to keep in mind that we have to restore the vaginal anatomy, visual function, sexual function and quality of life. For this assessment we have required some indicators. These include subjective and objective indicators. Objective indicators is the PAPQ, pelvic organ prolapse quantification system, which you can assess the improvement quantitatively. It looks very complicated, but once we get to use that, it will become easy. So this is a diagrammatic representation of PAPQ, and this is the staging of PAPQ. And subjective assessment also we can do with some indicators like pelvic floor distress in very short form and pelvic floor impact questionnaire, obstructed defecation syndrome questionnaire and Rome's criteria. With this we can ask these contain some questionnaires. We can ask the patient and we can give some indicators. With this we can assess subjective satisfaction of the patient post-operatively. Management contains conservation and surgical. Conservative management includes pelvic floor exercises. These are temporary, these are not permanent. We can give suggestions these pelvic floor exercises for the patients who are having stage 1 and 2 prolapse. We have to counsel the patient. Some rural area patients, if tell them do pelvic floor exercises, if you counsel them, they will get like they understood, but actually they won't understand. So we make them counsel, we make them educated that how to do the pelvic floor exercises, how many times we have to do, and the basic advantage and basic mechanism we have to explain them. Coming to the pessaries also, this is the temporary. We have to choose the patients who don't want surgery, who wants to delay the surgery. For them, we can advise the pessaries. Disadvantages of these includes like vaginal infections, different in sexual function, needs regular follow-up. So while it needs proper ingestion, it should be changed and cleaned regularly. Otherwise, it leads to vaginal infection. Can use lubricant and vaginal clean. Patient education is very important in while using the pessaries. When should follow, how to clean, how to come up with any warning signs. Coming to the surgical management, it includes vaginal, abdominal and laparoscopy. Apical suspension procedures include so many. In the vaginal, it includes vaginal, abdominal and laparoscope, vaginal uterosacral ligation, microculoplasty, sacrospinal ligament fixation, high uterosacral ligament like this, hysteroplexy, and abdominal wall suspension, uterosacral ligation, sacrocolpopexy, laparoscopic wall suspension, uterosacral ligation, and sacrocolpopexy. Right, coming to the uterosacral suspension, here we are suspending the wall to the uterosacral ligament. So it's an intraperitoneal mechanism. Here you are seeing the image where that red color one is the what we are suspecting this to the intrasacral ligament. The procedure here we have to retract the rectum medially and push the bladder anteriorly and dissect the intrasacral ligament, palpate the ischial spine 1 centimeter above it. We have to palpate the intrasacral ligament and take the sutures, and after that plug it into the vaginal cuff, and ends should go anterior and vaginal. Bilaterally we have to do this. So this is one intrasacral ligation, how it looks like abdominally. And one precaution we have to do while ligating the intrasacral ligament is, you observe that lower 1/3 of the ligament is free. 2 centimeters above it contains the back, behind the intrasacral ligament contains some vessels and nerve fibers, nerves. So we should take care while taking the suture. It should be just 2 centimeters proximal to the ischial spine. More than that we can't take. There might be more chances of injury to the nerves and vessels, which may cause post-operative pain in the buttock and in the region of the vulva and thigh. So care should be taken. One more complication of this intrasacral ligation is, there might be injury to the ureter or ureter thinning will be there. So to prevent this complication, we have to lift the intrasacral ligament up with Alice lump to little upwards, so that we can avoid damage to the ureter. And one more thing, you can palpate the ureter sometimes by sweeping your finger laterally vaginal wall, lateral pelvic vaginal wall. So advantages is a high success rate, low reoperation rate. Complication like I said, ureteral obstruction, bowel bladder injury, H2S nerve injuries cause pain. So we can prevent by lifting the intrasacral ligament and taking suture just 2 centimeters above the ischial spine, not more than that. This is a small surgical video where we operated. Sorry, this video is not going. Coming to the next thing, coccygeal sacrospinous ligament fixation. It's a true pelvic ligament. It's ligated just below the coccygeal muscle. That's why we can call it as a coccygeal sacrospinal ligament fixation also. Here we can have two approaches: posterior approach and anterior approach. Mainly we are practicing in our hospital posterior approach. We dissect the rectum, we enter into the pararectal space. From there we do the blunt dissection and identify the sacrospinous ligament by palpating the ischial spine, and then we ligate the sacrospinous ligament to the vault. And here also we have to take it. You can observe that here in the this middle part of the ligament is the same side to take suture. Above that and below that having nerves and vessels. So while taking the suture, we have to. It's like 4 centimeters in length from ischial spine to the sacrum. So when you are taking the suture, you have to take the middle part of the ligament, so that you can avoid injuries to the any nerves or vessels like internal pudendal artery and sacral plexus, brachial plexus. You can avoid injury to these nerves and vessels if you take middle third of the ligament. If you take immediately above the spine and more proximal, there is a chance of injury to the vessels. So advantages like high anatomic success rate, less recurrence, complication, neuropathic pain, rectal injury, and brain loss will be there. So this is a. I'm sorry, videos are not there. This is a fixation. Coming to the Meckel's scaldoplasty, it's like 2 types: modified Meckel's and modified Meckel's. Meckel's initially described as it contains 2 to 3 internal sutures, 1 external sutures. Internal sutures includes sacrospinal ligament, posterior peritoneum, and opposite sacrospinal ligament. External sutures includes vaginal epithelium, ipsilateral intrasacral ligament, and not sacrospinal, intrasacral ligament, and opposite side intrasacral and opposite side vaginal epithelium. With this, we have to expose the intrasacral ligament and then take the sutures. First, we have to tie the internal sutures, followed by the external suture. But nowadays we are doing the modified Meckel's, in which we are doing taking the suture first through the posterior vaginal wall, going to the one side uterosacral ligament, followed to the posterior peritoneum, coming to the opposite side uterosacral ligament and coming to the same side where you enter into the posterior vaginal epithelium and ligate it last. This is a modified method which we are doing in our hospital and routinely, which is simple work. Complications like ureter should be you should be careful about ureter. And comparison to the Meckel's scalloplasty, high uterosacral suspension, and sacrospinal fixation, if you compare those three, there is no much difference you can observe. All subjective and objective success rates, recurrence rates, almost more or less little bit same. So based on the patient condition and based on the surgeon expertise, you can use which method is good. Coming to the abdominal and laparoscopic colpopexy, in this the procedure is same in abdominal and laparoscopy, the approach is different. So I can explain both in the same procedure. Here first we can have to cut the peritoneum, enter into the retroperitoneum by cutting peritoneum over the anterior sacrum. So expose the anterior sacral ligament. Here and vagina should be dissected with the end-to-end anastomosis scissor, the one with ball thing you are seeing. So with traction and counter-traction method, you separate the posterior and anterior void from the blood, posterior part of the vagina from the rectum, anterior part of the vagina from the bladder, and you have to take the tape. It should be 3 to 4 centimeters in width, 40 centimeters in the length. You make it as a Y shape. One end should be attached to the fibromuscular layer, the posterior part of the vagina, and one end should be attached to the anterior part, the fibromuscular part of the vagina. And this end should be attached to the lateral part of the vagina, and one end should be attached to the sacrum. And this should be graft should be laid hollow in the hollow part of the sacrum. Avoid tension so that dyspareunia and short vagina should be avoided. These are the main. So whenever you are doing this surgery, you should be careful about the middle sacral artery, which is lying immediately to the anterior sacral ligament and nerve vessels. So you should go into the proximal part of the promontory, so you can avoid the injuries to these structures. This is a durable procedure which we can correct occult SUA also in this with this procedure, and modified other sling surgeries also we can operate with this. And complications and injury to the vessels and nerves and mesh erosion will be there. We have to discuss the complications of the mesh with patients before going into the surgery. Sacrocolpopexy success rate is high, but compared to other mesh erosion, complications are more. No one surgical approach is appropriate for all patients. Surgeon must be adapt to multiple approaches and procedures to effectively care for all patients, and sacrocolpopexy is only one option, it is not the option. And solid support of the vaginal apex is a cornerstone for good vaginal wall prolapse repair. So whatever, like if anterior prolapse, 50% of the anterior prolapse is associated with apical prolapse. So whatever prolapse you are doing, you have to suspend the apical, you have to correct the apical prolapse compulsory. Otherwise recurrence rates are high. Coming to the anterior vaginal prolapse, it contains central, lateral and apical things. Main thing is restore the anatomy. Steps in the anterior repair is you have to incise the anterior vaginal one and dissect the fibromuscular part of the anterior vaginal wall and plicate it. This is a simple one. Paravaginal report includes we have to go little bit laterally into the until we reach the arcus tendinous fascia. We have to attach the arcus tendinous fascia to the fibromuscular layer of the vagina. Unless if you didn't identify the proper diagnosis, if you support the central one, there is a chance of recurrence. And pelvic floor repair includes posterior part of the perineum, like same like anterior corpus only, and along with the thecal repair the perineopathy. Anthosil and obliterative procedures who are not fit for surgery, colpopexy who are not fit for surgery in comorbidities are there. The simple one approximate the anterior and posterior vaginal wall. Myopathy also you can do. And preventive steps include whenever you are doing NDVH and either TLS, you should suspend the apex to the uterosacral ligaments compulsory, either NDVH, DH or TLS, so that recurrence options are less wall collapse. So mesh usage is a dilemma based on the different surgeons have different opinions. So it's based on your personal opinion. Suture material is delayed observable and non-observable. It's your personal opinion. And coming role of robotic surgery is minimal. Role of MRI is also minimal. Conclusion: proper identification of defects and repair and wall suspension at the time of VH is very important to prevention of the valve collapse. Objective and subjective evaluation is also very important. This is a pilot study where we did wall suspension and we observed very less wall collapse. So surgery should fit the patient should not fit the surgery. These are my references. And I would like to thank JP sir, who are my great surgeon, great laparoscopic and wellness surgeon, who is my teacher, and Sundari ma'am, our professor, Jyoti Suchitra ma'am, who is our HOD and our mentor and guide and everything for us in the department, and Sumati ma'am, and also Auntie Hospital and staff. Thank you all. Thank you organizers for giving this opportunity.